Hi, good afternoon. I'm Dr. Neil Martin. I'm a neurosurgeon here at UCLA. I've been here for 28 years. Over that time, I've done about 5,000 operations and managed more than 1,000 patients with vascular malformations of the brain. We're going to talk today about a particular type of vascular malformation, arteriovenous malformations in the brain. An arteriovenous malformation is a cluster of abnormal blood vessels within the brain that's been present since birth. This is a birth defect of sorts. It's almost like a birthmark on the brain. It's congenital. That means it's present at birth, but it's not necessarily hereditary. Only in rare cases are AVMs hereditary. The issue with AVMs, the symptoms that they cause and the problems include seizures, hemorrhage in the brain, and in some cases headaches. Those are the key issues. And treatment of arteriovenous malformations is primarily directed at relieving those symptoms by removing the arteriovenous malformation, or AVM as we call it, completely from the brain. We're going to talk today about the different techniques involved in treating arteriovenous malformations, but I want to talk a little bit up front about what the AVM looks like, what is comprised of, how it relates to the brain, and then talk about what we call the natural history. In other words, how do these abnormalities behave if they're not treated? Let's start with a view of an AVM. This is the surface of the brain with an arteriovenous malformation here. You can see that it is quite well limited and distinct from the brain. It's a cluster or tangle of abnormal blood vessels, often located on the surface of the brain, sometimes deep within the structures of the brain, and any brain area can be affected. The cerebrum or the cerebral hemispheres, the cerebellum or the brainstem. On an angiogram, this is an arteriogram. This is a diagnostic study done by injecting through a catheter dye and taking a series of high-resolution pictures as the dye flows with the blood through the structures of the AVM. So these blood vessels are normal, and this obviously stands out as something distinct. This is a cluster of abnormal blood vessels in the brain. The AVM really has three parts to it. It has the arteries, the high-pressure blood vessels coming from the heart, going to the AVM. We call those the feeding arteries. There's the core of the AVM, or the central component. That's where the blood vessels of the AVM direct the blood directly from the arteries to the veins, the low-pressure blood vessels that take the blood back to the heart. And the central component is called the nidus, or the core of the AVM. So this is the nidus. Here are the arteries feeding the AVM, the feeding arteries, and here is the large draining vein coming out of the AVM. We can see the feeding arteries coming in and draining veins coming out of this AVM on the surface. Now, before we talk about treatment of AVMs, let's talk about the behavior of AVMs. When patients come in with an AVM that's caused a brain hemorrhage, there's often a neurological deficit. That may be speech impairment, it may be paralysis of an arm and leg, or it may be coma. About 10 or 15% of the time when an AVM ruptures, the rupture is so severe that the outcome is death, that it is a fatal hemorrhage from the AVM. 25 to 35% of the time, the hemorrhage from the AVM causes damage to the brain that results in a neurological deficit like speech impairment, stroke-like symptoms, hemiparesis, or weakness on one side of the body. Not all AVMs come to light after they've caused a hemorrhage. It's not unusual today to find a patient who's had some headaches or a bump on the head who gets a brain MRI scan, and we see an arteriovenous malformation on the diagnostic imaging test, CT scan, MRI scan, sometimes angiogram, and we detect an arteriovenous malformation before it's ever ruptured. This can happen in children and adolescents. It can happen in adults, even elderly patients. And then we're faced with a decision: what do we do about this accidentally discovered arteriovenous malformation? How will it behave? What is the risk if it's left alone? and how might it be treated. Now, as far as the risk, if the AVM has caused a hemorrhage, the risk of another hemorrhage in the future is high enough that the AVM should be treated by one of the techniques that I'm going to talk about: surgery or embolization, that is injecting through a catheter particles or glue-like substance to block off the AVM, or radiation therapy called stereotactic radiosurgery. Those are the three kinds of treatments. When we have an arteriovenous malformation that is unruptured, there's been no bleeding, it's detected by a headache or a scan done for some other reason, then we have to predict what the risk of having a hemorrhage in the future might be. And the newest information, particularly from a research study done in New York called the Aruba study, we're finding that many unruptured AVMs seem to have a relatively low risk of causing a hemorrhage in the future. Basically, if the AVM is small and on the surface and there's been no hemorrhage, the risk of having a hemorrhage is about 1% per year, or possibly even lower than that. So over a relatively short and midterm length of time, 5 years, 10 years, the risk of rupture from the AVM is relatively small, and in some cases we recommend not to treat the AVM at all. AVMs that are located deep in the brain or in the cerebellum, the posterior part of the brain, seem to have a higher risk of future hemorrhage, and those AVMs might be recommended for preventative or prophylactic treatment. In other words, treatment and obliteration, removal of the AVM so that a hemorrhage is avoided. So looking at the AVM and its features helps us to predict what the future risk is and decide whether or not treatment is necessary. And we'll get into this in a minute. Looking at the AVM also helps us predict how risky it might be to treat the AVM with the various techniques that are available. Because for each AVM we have to make a risk-based decision on both non-treatment and treatment, and then we have to select the appropriate treatments for that particular AVM. The decision really requires the evaluation by an experienced individual, usually a neurosurgeon, who has treated many AVMs in the past. So here's an example of this AVM. Here's the core of the AVM here, the nidus, and we can see a diagram of what the AVM looks like on the surface of the brain here, sitting here next to a critical area that controls movement on the opposite side of the body, the hand and arm on the opposite side of the body. This is one where we have to be very careful with any treatment to achieve our key goals. Number one, protect function and quality of life. That means make sure that any treatment we use has a very minimal chance of causing neurological problems like weakness, numbness, speech impairment, or other neurological deficits or disabilities. And the second goal is to eradicate the AVM completely. Now, treatment of an AVM in large part is an all or none situation. Removing half the AVM does not reduce the risk by half. Removing 90% of the AVM does not remove the risk. And in some cases, disturbing the AVM actually raises the risk of a future hemorrhage. So treatment's got to be complete. It's got to be completely eradicated in order to eliminate the future risk of hemorrhage. Diagrammatically, this is what the AVM looks like. These are the arteries coming from the heart, the high pressure, high blood flow feeding arteries. They send small side branches into the AVM core or nidus, or they may dump circulation directly into the AVM, and then the blood flows out of the AVM through enlarged veins, the draining veins. So there are the feeding arteries, the nidus, and the draining vein. Our goal in treating this is to block each individual blood vessel right as it goes into the AVM, remove the nidus or obliterate it, occlude it, block it off completely, and preserve the circulation in the normal brain blood flow, in the normal brain arteries, so as to prevent a stroke in the surrounding brain areas. Historically, this is what was done. An AVM, represented here by the small cross-sectional view of blood vessels in the brain, a large area of the brain was removed that contained the arteriovenous malformation. Today, we're much more precise. Using microsurgical techniques, it's possible to carefully separate the blood vessels of the arteriovenous malformation, block off the feeding arteries one by one, and then remove the core, the nidus, from the brain and protect the surrounding brain tissue with minimal or no damage to the brain tissue. And this is what it looks like. This might be the AVM nidus. They often look like this on the surface, cone-shaped. Feeding arteries coming in that are being blocked off, and then the nidus is separated from the brain and removed, and the feeding vein and the draining vein is blocked off and cut so that the whole nidus is removed. One is left with a small cavity in the brain where the AVM was located, and all the blood vessels coming in and going out of the AVM are thoroughly sealed so there can't be any postoperative bleeding. The blood vessels in the AVM are extra abnormal, unnecessary blood vessels. They don't serve any useful purpose. They can be removed without disturbing the circulation of the brain. And this is what the high magnification view of the surface of the brain looks like as an AVM is just in the early phases of being dissected, removed, separated from the surrounding brain. So you can see that there's quite a nice cleft that's been created surgically between the normal brain tissue here and the arteriovenous nidus. And you can see it's almost like a tumor in its configuration. It can be separated very precisely from the brain tissue and removed with little disruption of the normal brain. We see a few small arteries coming in here and here and here, and those arteries are going to be coagulated, sealed, and divided in order to remove the AVM. Here's an example of a small AVM in the frontal lobe on an angiogram. This is the diagnostic test that involves injecting dye through blood vessels into the brain to identify the AVM. And we can see the normal pattern of blood vessels here and the arteriovenous malformation up on the surface right in this location. This woman had her AVM diagnosed after she had a seizure, a convulsion. And in an adult, we assume after a single seizure that there's the possibility of having some sort of abnormality in the brain, either a tumor or a vascular malformation. And so a diagnostic test, usually an MRI scan today, is done in these patients to identify the source of the seizure. And when an AVM is discovered, then we have to decide what to do with it. Here's another example. Here's an angiogram in the early phase with the blood vessels beginning to be filled with dye. We begin to see the AVM here in this location. As the dye circulates through the blood vessels, we see the large nidus of the arteriovenous malformation. And in this case, after surgery has been done, we can see that we've preserved the normal blood vessels, and that large nidus seen here has been removed after surgery. So a normal pattern of circulation is restored after surgical removal. Here's another example. This is an arteriovenous malformation close to language areas but not involving them directly on the left side of the brain, and it's in a cleft of the brain called the Sylvian fissure. This is one of the folds of the major folds of the brain. So we see the AVM nidus here. We see the draining vein coming out and some of the small feeding arteries going into the AVM. That has to be exposed so it can be visualized surgically by separating the folds of the brain, coagulating one by one the arteries coming into the AVM, and then removing the AVM. So here's a view of an MRI scan, a typical diagnostic test done for AVMs. You can see the AVM located in this region from the side view and in this region from a cross-sectional view. We can do a three-dimensional reconstruction of the brain surface and begin to see the vein that goes into the AVM, that is the guide. So we can go down this cleft and identify this view. We've now subtracted digitally from the MRI scan the brain tissue so we can just see the blood vessels and see the AVM clearly in this, it's almost like a 3D X-ray vision view of the brain that allows us to plan very precisely where we need to enter the brain, how we need to deal with the blood vessels, and how the AVM can be removed completely. So here's that same AVM. The first view of the surface of the brain shows the draining vein coming out. We've labeled the language areas by stimulating the brain. And then we'll go into this cleft in the brain, the Sylvian fissure, to identify the AVM by separating the folds of the brain, removing it completely. We can see here just that small opening into that cleft in the brain. The AVM's been removed, and the final view shows no residual AVM here at all. Here's the AVM before surgery. Here's the AVM after surgery, completely removed with preservation of the normal circulation. That's exactly what we want to see when we treat an AVM, complete eradication, complete removal of the arteriovenous malformation. In some cases, AVMs, particularly very large AVMs, have to be reduced in size in order to make surgery safer. They have to be reduced in size to minimize the chance of bleeding during surgery, which is one of the key risks. And today that's done with a technique called embolization. Through a catheter introduced into the artery, the same way a heart angiogram is done or a brain angiogram, the diagnostic study is done, the catheter is passed up into the arteries of the head, and a microcatheter, we're talking about a catheter that is smaller than a piece of spaghetti, like a piece of angel hair pasta, that floats up through the bloodstream into the blood vessels here of the arteriovenous malformation, and a glue-like substance is injected into the abnormal blood vessels to progressively block them off. And once they're blocked off, then they're easier to separate from the brain tissue. The surgery can be done safer with less blood loss, and it improves the results and reduces the chance that there's going to be some sort of problem with bleeding during the surgery or after the surgery. So this is embolization, one of the second techniques. Surgery is the first technique we're talking about. Embolization is a microcatheter technique done without open surgery, and that is done to remove, to block off the arteriovenous malformation. And then the final technique we'll talk about is radiation therapy in just a minute. But here's an example of a case treated with embolization. There's a very large AVM taking up most of the frontal lobe. It's about that size. Through these small arteries, the catheters have been introduced into the arteriovenous malformation. That's allowed us to block them off. So after blocking off some of the blood vessels, we can see that there's some reduction in the circulation in the arteriovenous malformation. Now normal blood vessels are more well visualized, and the AVM begins to be reduced. After a second embolization, it's further reduced, and that then takes an AVM that is looking like this, the black is flowing blood, to one that looks like this on a scan. The white is the glue-like substance in the AVM, and surgery can be done on this AVM, and we can end up with complete removal of the AVM in a much safer fashion. So embolization is often coupled with surgery as a pre-surgical step to prepare the AVM for removal. Here's another example. Here's an AVM that, this is a CT scan of the brain that shows that this is an AVM that's ruptured. The patient came in a coma, unable to respond to any requests or commands, and paralyzed on the right side of the body from this large hemorrhage. When we did the diagnostic study, the angiogram, we see the AVM here. Here's a large draining vein in the feeding artery, and another view of it. But we also saw that not only did that AVM come to the surface and derive some of its blood supply from surface blood vessels, but there were blood vessels coming into the deepest part of the AVM that would be very difficult to see and gain access to during the early phase of surgery. Those blood vessels have to be treated first by embolization. So these are the blood vessels coming into the deep part of the AVM. The brain surface is out here. And this is after the first stage of treatment, the embolization. These blood vessels have been partially blocked off so that much of the AVM that's supplied by the deep, inaccessible blood vessels is knocked out, and surgery can be done safer subsequently. So here's the AVM before treatment, and after the final treatment, we can see that the pattern of the blood vessels is restored to normal, and in fact, the hemorrhage was removed during the surgery, and this patient's speech and coma resolved, speech returned, and movement of the right side also recovered very, very well. So the optimal treatment, what we're looking for in the treatment of AVMs, is no treatment-related neurological problems like aphasia, speech impairment, or hemiparesis, movement impairment or paralysis, and complete AVM obliteration. That's complete and ideally permanent and ideally immediate. And of course, we're focused on rapid recovery, minimal convalescence, and minimal discomfort in the treatment of these patients. How do we decide what the risk of having a neurological problem after treatment with an AVM? The technique we use now is to assess the key factors that increase the complexity and surgical difficulty of an arteriovenous malformation. And that relates to a grading scale that we devised back in the 1980s. Robert Spetzler and I began studying AVMs at that point and devised a system to help predict what the surgical risk was. And that involves looking at the size of the AVM and its location adjacent to or distant from critical control centers in the brain, and the depth in the brain marked by the venous drainage pattern. And we gave points. A grade 1 AVM is small on the surface and easy to treat surgically, and a grade 5 AVM is large, adjacent to critical areas and deep in the brain, and much riskier to treat surgically. So here is a grade 3 arteriovenous malformation. It's large and on the surface, but it's not right next to the most critical area. Here's another version of a grade 3 next to critical areas, also with some deep component to it. So we're looking at size and eloquence. That means, is it next to a critical control center or not, or venous drainage. So size is key. Eloquence is the second thing we grade, and then the venous drainage, marking the depth in the brain. Because surgery results in complete, immediate elimination of the AVM in the vast majority of cases, in my experience, more than 98 or 99% of AVMs operated on are completely obliterated, the therapeutic technique which most effectively eliminates the risk of hemorrhage is surgical removal. But it's got to be done without causing neurological disability. That's the key issue. And in some cases, surgery is not possible. The grade of the AVM is too high, the surgical risk is too high, and alternative methods have to be used for treating it. In these cases, focused radiation therapy, stereotactic radiosurgery as it's called, or gamma knife treatment as it's often referred to, is a viable alternative. Let's talk about that. On the left side of the brain, your speech center is located just in the temple region. And the receptive language area, reading and comprehension of speech, is located just above the ear. And so if an AVM is located in those areas, then disrupting that area of the brain while removing an AVM may cause aphasia. In other words, disruption in reading or writing or other language functions. Here's an AVM that is located very close to the expressive language area controlling speech and writing, so-called Broca's area. We can see it right here. In fact, in this patient, in order to identify exactly where the control centers were, part of his operation was done awake. We stimulated the brain and found that the AVM was entirely surrounded by critical control centers for language function. They're labeled by these numbered tags that we put on the surface of the brain as we stimulated and mapped out language function during his surgery. We found that the AVM could not be removed safely surgically. We stopped the operation, and he then subsequently had another form of treatment, the stereotactic radiosurgery. Historically, this was done with the Lexell gamma knife. And this is a picture of this. This is a device that the patient is rolled into on this special table, and radiation is administered in a highly directed and focused manner to the AVM. The brain receives very little radiation. The radiation is concentrated on the AVM itself, and that process initiates a scarring or fibrosing process in the blood vessels of the AVM. They gradually shrink, close off, shrivel up, and the AVM can disappear completely if it's not excessively large. This technique has treated now hundreds of thousands of patients with arteriovenous malformations around the world, and is quite effective if the AVM is on the small side. Today we're using a device that is a robotic image-guided device that accurately beams the radiation therapy to the AVM, and in contrast to the original Lexcel technique, we don't have to use just a spherical spot size to hit the AVM, but the beam can be shaped for an irregularly shaped AVM or tumor in other cases. So this is what the device looks like. The arm rotates around the head, and the AVM is hit by beams coming in from various different directions, so that the amount of radiation on this small AVM in this location is aggregated or focused on one particular area, largely to the exclusion of radiation exposure to the rest of the brain. And the area that gets the most radiation exposure is the area where the vessel effect takes hold and the AVM is gradually fibrosed. Here's an example. Here's an arteriovenous malformation in a 28-year-old man who had no neurologic deficit, only headaches, and we found this AVM. We could see that on the MRI scan and on the angiogram that this was located immediately adjacent to the area controlling his right arm and hand. Our concern was that any attempt to remove that AVM would leave him paralyzed and with a neurological disability. That pushed us toward considering an alternative treatment, and we elected in this case to use focused radiation therapy, radiosurgery, using the robotic Novalis device I just described. Here's how this looks on an angiogram. These concentric circles indicate how much of the radiation is concentrated on the AVM and how much might bleed over or extend over onto normal brain tissue. And the vast majority, 85 or 90% of the radiation is hitting the AVM alone. And what we can see here's that AVM before surgery. Some of the blood vessels were blocked by embolization, and here's 19 months later. This AVM is completely gone. You can't see it on any of the views. And that young man who worked at UCLA when the AVM was discovered continued working here for many years after that with no neurologic problems whatsoever. And he did not require open surgery. This is an outpatient technique administered non-invasively, and now there's no pins in the head or no head frame. It's done purely by positioning the head precisely and using image guidance. So it's a painless outpatient procedure. In some cases it can be done in a single treatment and the patient goes home immediately after. In some cases it takes a series of treatments, especially if the AVM is a bit larger. So this is an overview of how arteriovenous malformations are treated. And let me go over the key points. AVMs are congenital. One is born with them. Congenital abnormalities that consist of a cluster of abnormal blood vessels. They are separate from the brain tissue, but within the brain tissue. Arteriovenous malformations cause headaches, seizures, and brain hemorrhage, and the brain hemorrhage can be quite serious. When an AVM is discovered that has caused a hemorrhage, then in almost all cases it has to be treated, and that treatment often requires surgery, sometimes preceded by embolization, the process of injecting a glue-like substance through the blood vessels. When the arteriovenous malformation has not ruptured, then treatment is only recommended for those cases where surgery can be done with a very high confidence that there will be no neurologic problem. If the AVM is small enough, it can be treated alternatively with focused radiation therapy. The three key kinds of treatment are surgery, embolization through the blood vessels to glue the AVM, and stereotactic radiosurgery, the focused radiation therapy. And with this combination of treatments for key AVMs, the vast majority of AVMs that are dangerous can be treated effectively. So I'd like to take any questions that might be coming in about the management of arteriovenous malformations now. So the first question is, what are the treatment options for children with arteriovenous malformations? Well, the same options exist as I've just described. I primarily have focused on cases in which the patients were adults, but the same can apply in children. If the child has an AVM that's caused hemorrhage, then we make a very concerted effort to treat it as safely as possible. Often that requires surgical removal, in many cases preceded by embolization. But not every case needs embolization. We use embolization selectively only when it's really going to facilitate the surgery, because the embolization procedure itself has its own risks of causing damage to blood vessels, dye reactions, in rare cases causing stroke or actually precipitating hemorrhage from the AVM. So the same options exist for a child. What's unique about children? First, there is a very long period of time, their natural lifespan, ahead of them, and there's a long period of time during which they're at risk for having a brain hemorrhage. So we are a bit more direct at trying to treat and eradicate AVMs in children to protect them, their future potential for quality of life. The other unique thing about children is that they often have relatively diffuse AVMs. The blood vessels have not coalesced into a compact nidus, and that influences how the surgery is done and influences how the radiation therapy is done. Finally, children are very resilient. They get through surgery with fewer complications and problems than adults, and if there is, God forbid, any neurologic problems related to hemorrhage from the AVM or to the treatment itself, then children have a greater capacity for brain recovery and recovery of function than adults do in most cases. That's due to what we call the plasticity or recoverability of the brain. So how is stereotactic radiosurgery used to treat brain tumors and arteriovenous malformations? Well, let's talk about AVMs first. Stereotactic radiosurgery is used for those AVMs that have an acceptable size and configuration for radiation therapy, for stereotactic radiosurgery, and in whom there are some symptoms or findings to suggest that their future risk is significant. As a general rule, stereotactic radiosurgery is more effective at treating smaller arteriovenous malformations, and so we generally use it for small AVMs that are located in an area where surgery is going to be risky. Small superficial AVMs on the surface of the brain often can be treated with little or no risk surgically, and that provides immediate obliteration of the AVM. But small arteriovenous malformations in the depths of the brain or adjacent to critical structures are ones that are often referred for stereotactic radiosurgery, because there's less risk of surgically induced damage to surrounding areas that might result in neurologic problems. So a small, deep arteriovenous malformation in the brain, particularly if it may have caused a hemorrhage at some point, is something that we would recommend for treatment with stereotactic radiosurgery. There are a couple of drawbacks. One is it's much less effective for larger AVMs, larger than about an inch in diameter. The chance of the AVM disappearing with radiation therapy goes down. So larger AVMs don't respond as well. Second, the process of obliteration of the AVM disappearing, shrinking, scarring off after radiosurgery is something that takes time. It can take 1, 2, or 3 years in some cases. So while the AVM is shrinking and disappearing, there's still a risk of bleeding from the blood vessels of the AVM that remain open. So there's a lag phase. There's a delay before one experiences complete protection from future hemorrhage from the radiosurgery. So how common are arteriovenous malformations? Well, fortunately, they're not terribly common. We see hemorrhage from arteriovenous malformations in somewhere between 2 and 4 patients per 100,000. So 20 to 40 per million is a reasonable estimate. There may be then less than 15,000 patients a year who come to light with an arteriovenous malformation. Now, since UCLA is an AVM center, we tend to see these patients coming from a large geographic, a large regional area for treatment. So it's common for us to see 1 or 2 patients a week with arteriovenous malformations. What factors influence whether or not an AVM should be treated? Well, here are the key factors. First and foremost, if the AVM is ruptured, if it's caused a brain hemorrhage, then we generally recommend treatment. And then we decide which treatment is going to have the least risk of causing any neurologic problem and the highest chance to completely obliterate the AVM. And often it's a combination of surgery with embolization, and in some cases surgery and stereotactic radiosurgery. What do I mean by that? For large AVMs, focused radiation therapy, often given in a few doses, may not cure the AVM, but it may shrink it sufficiently to make it acceptable for treatment with subsequent surgery. That may take 2 or 3 years, but we've had a number of cases where very large, essentially inoperable AVMs have been treated with focused radiation therapy, and then we've been able to remove them safely 2, 4, 5 years later. The other issue in AVMs that have not ruptured that is critical, it really is the location of the AVM. Superficial AVMs on the surface of the brain seem to have a lower risk of hemorrhage than those deep in the brain or in the cerebellum or brainstem. So superficial arteriovenous malformations on the brain surface are ones where we may consider leaving them alone, not attempting any treatment, particularly if they're close to or adjacent to or incorporating critical control centers on the surface of the brain that relate to language function, reading, writing, speaking, comprehension, that relate to movement, critical sensation, that relate to other sensory functions like vision. So the judgment has to be made individually on each case. The judgment is dependent on the predicted future risk of hemorrhage. That depends on whether or not it's bled and what its location is. And it depends on the predicted risk of having a neurologic deficit from the treatment. That may depend on the surgical grade, the Spetzel-Martin grade that applies to that arteriovenous malformation. Any other questions? So thanks for your attention today. This video will be available. The recording of this webinar will be available on the UCLA Neurosurgery website, and we are in the process of uploading these as well to YouTube so that they're widely accessible and can be reviewed again in the future. Thanks for joining us, and thanks for your participation in the webinar.